Shared decision-making is the process by which a patient and a clinician work together, have a conversation, partner with each other to identify the best course of action, the best treatment, the best test to do at this point in time. It involves sharing information. The clinician will share information about the alternatives and their relative pros and cons. The patient may want to share information about their prior experience with treatments, information about their own values, their own preferences, their own goals and expectations. May also have information that they may have gathered by talking to friends and family, by doing their own research, looking up things on the web. And when patient and clinician come together to share that information, the hope is that they'll be clear about what are the things that begin to matter to the patient. And then there'll be a process of deliberation, of consideration of the alternatives. And very much over time, the best course of action will be arrived at by consensus, by agreement between the two parties. That's what shared decision-making is. Making it happen in reality is tougher than imagining this simple but important or vital conversation. Making it happen in reality means that the clinician has to be prepared with that information, be able to share it with the patient in ways that the patient can understand and engage with. They'll have to have the time to do it. They'll have to have the quiet in the office to do it. They should not be interrupted. They should be able to be ready to have those conversations. The patient, on the other hand, also has to be ready to understand, to participate, to bring forward their concerns, to share those with the clinician. So both the patient and the clinician are actively involved in shared decision-making. It's not a passive process. To make that happen, we are producing tools that help the clinician convey that information to the patient, again, in ways that are engaging, that are practical, that communicate effectively and accurately what is it that we know and we do not know about the alternatives and the patient's in the patient situation. We have developed several of these tools that we make available on our website. These tools are freely available. Patients of our patient advisory group help us develop these tools along with colleagues, and so we make those available freely for people to download and use. But they're not to be used by the patient alone at home. They are to be used with the partner, with the clinical partner, with the clinician, a physician, and involved nurse. There are tools to create conversations. We expect those conversations to be meaningful, to be relevant to both the patient and the clinician, and to give them a confidence at the end when they reach the decision, that the decision that they've reached really reflects not only the best available research evidence, but also the values and preferences of this particular patient. We have ways of measuring that has happened, but the fundamental measure that we have done a good job in terms of shared decision-making is that patients walk away feeling that they know enough about the options, that knowing that the option that was taken up was probably the best given the circumstances, and that they are willing and ready to act on that option and to stick to it over time, to learn of the effects that that option will have on themselves. Our group is particularly interested in doing this work in patients with chronic conditions, which gives us an interesting opportunity because as patients go in their journey, they may learn more about themselves, about the treatments, about how the treatments react on themselves, and calibrate those decisions over time, refining them and making them better. For that purpose, they need an able and willing partner in their clinician. At the end of the day, we think that through shared decision-making, we're bringing about a real patient revolution by which patients' needs and wants are at the center of our clinical activity.